want to thank everybody for joining us today. We'll get started. Today's session is Sleep Matters, a review of sleep issues in Parkinson's. We want to thank Dr. Vaou for coordinating this presentation with us. I'll tell you a little bit about Dr. Vaou in just a moment. Again, if you have any questions that you'd like answered at the end of the presentation, please put those questions in the chat or the Q&A button. Thank you. If you can move to the next slide, please. The APDA has been in operation for decades and offers programs and services to the PD community in Massachusetts and the surrounding states. We've received a very large response for this presentation. My name is Bill Patchane. I'm the Executive Director for the APDA in Massachusetts here in the Northeast. Over the course of the last 5 to 10 years, there's been a tremendous amount of progress in understanding and treating PD. As you may know, PD is highly individualized from person to person. Not all that is discussed today is relevant to everyone. The healthcare team must be familiar with the signs and symptoms, treatment strategies, and how PD impacts the individual patient. Treating PD requires a team approach. Today, we are providing information that is not intended as medical advice. I'd like to introduce our speaker for today's presentation, Dr. Vaou. Dr. Vaou completed her neurology residency at New York Medical College and served as chief resident. She then pursued fellowships at Boston University School of Medicine in movement disorders and in sleep medicine. Following her fellowship training, she practiced at the Norrin Neurological Clinic in Minneapolis. She also served as the medical director of the APDA Minnesota chapter for 5 years. At St. Elizabeth's Medical Center, Dr. Vaou's expertise is treating patients with Parkinson's disease, atypical Parkinson's, essential tremor, and other movement disorders. She is also a board-certified sleep specialist and treats sleep disorders in patients with movement disorders. I'd like to introduce Dr. Vaou and thank her for taking the time to make this important presentation. Thank you, Dr. Vaou.
Thank you so much. Thank you, Bill. Thank you so much. Thank you, APDA for inviting me at this very important topic in patients with Parkinson's disease. Sleep is quite common, as we will spend discussing over the next hour or so. So I'd like to go over the most common sleep disorders that are affecting patients with Parkinson's and how we can treat those, recognize them, and treat them. So I'm just going to start with some basics. I also want to thank everyone who's joining us today. And just starting a little bit about what Parkinson is. It was first described in 1817 by Dr. James Parkinson's. And what it really is, it's a loss of dopamine producing cells in the brain, which results in less dopamine. And we know that it's becoming more and more. The disease is increasing in what we call prevalence. So in 2010, about 680,000 individuals over 45 years of age had Parkinson's. In 2020, it's roughly at 1 million, if not over. And in 2030, it's projected to be higher than that, and 1.2, 1.3 million of patients in the US who would have Parkinson's disease. Now, we do know that there's a loss of dopamine in a part of the brain called substantia nigra. And if we look at an area in the brain called brainstem, we can see inclusions of particular protein inside those cells that was discovered in 1912. And it's composed of alpha-synuclein. These are called Lewy bodies. And that is the hallmark of the disease. That's the pathophysiology that we know is happening in patients who have Parkinson's disease. What we also know is that the disease starts, this is the brain, looking at it from the side, and we do see that we know that the disease starts quite lower in the brain. This part is called brainstem. And the first stages, it doesn't involve the entirety of the brain, just only this part. And it affects the autonomic, central nervous system, and some olfactory disturbances. As the disease progresses, and we're talking about stages 3 and 4, then this pathophysiology expands to involve more of the brain and the brainstem. And that's when we start noticing the motor symptoms, the tremor, the stiffness, and the sleep disturbances. And as the disease keeps on progressing, involving the rest of the brain, that's when we start noticing problems with mood, problems with cognition, etc. So that's kind of the progression and staging of Parkinson's disease. As we know, Parkinson's disease has mainly is characterized by the motor symptoms, the tremor, the stiffness, the slow movements. However, that's just the tip of the iceberg, because under it, we can see a lot of these what we call non-motor symptoms, problems with smell, problems with mood, sleep disorders, autonomic dysfunction, fatigue, etc., just to name a few. So we will be focusing today on sleep disorders, and they are quite common. Actually, they're as common as 90% of patients who have Parkinson's complain of some type of a sleep disorder. And we're going to name and go over some of the most common ones that patients with Parkinson's have, and talk about their treatment. So I'm going to talk about the REM sleep behavior disorder, excessive daytime sleepiness, insomnia, restless leg syndrome, and periodic limb movements of sleep. Now, I chose this slide just to kind of separate. There's some gender differences in patients with Parkinson's disease. We know that women in Parkinson's have complained more of fatigue, they have more pain, anxiety, depression, and restless legs is more common than in men. Now, men who have Parkinson's complain more of daytime sleepiness, sexual problems, olfactory problems, or cognitive impairment. Let's talk a little bit about REM behavior disorder. And I want to make some also clarifications, because over the years, while treating patients with sleep and Parkinson's disease, there's always this misunderstanding about what REM behavior disorder is, why we should treat, and how we should treat. So typically, normally, when we sleep, our tone, our muscle tone, when we dream, our muscle tone is absent. In other words, we are paralyzed so that we don't act out our dreams. Now, that does not happen in patients with Parkinson's disease. So what happens is their tone is there, it's present, so they can start acting out their dreams. Now, that's not actually, it's not very safe. It can be very disruptive for their partner's sleep, for their own sleep, and it can also lead to injury. And there's a big spectrum. So patients might just smile or talk or start laughing. They might start gesturing or yelling, or get even more violent, where they start punching and flailing and kicking. They may sit up from the bed or jump out of the bed, start running. So it can be from very simple or mild, where we don't need to treat, to active, more aggressive and dangerous behavior. We typically diagnose this clinically, but the hallmark, the gold standard of diagnosis is a sleep study, where we actually see the behaviors, and we actually see that the patient's muscle tone is present when they're dreaming, when they're in what we call the REM sleep. We see that even up to 50% of patients would have REM behavior disorder. And what's interesting is that REM behavior disorder precedes the onset of Parkinson's disease. So if someone is diagnosed, they may have had REM behavior disorder for at least 10 years or 15 years before the tremor started or before the stiffness started. So it can serve as an early marker for Parkinson's disease. However, it's not specific to Parkinson's disease. So, and I'll talk about this in a little bit. It's very important to recognize REM behavior disorder because it can lead to injuries to the patient, injuries to the bed partner. It can have dislocations, fractures, etc. So when this happens, we obviously need to treat. Patients who have hallucinations or dementia or on antidepressants or are withdrawing from alcohol have a higher risk of having REM behavior disorder. Now, there were some interesting studies have been done on what we call idiopathic REM behavior disorder, which is basically someone having REM behavior disorder with no diagnosis of Parkinson's disease. So what they did is they looked at those patients longitudinally over 15 years, and they wanted to see and follow them and see whether they would convert to Parkinson's or any other neurodegenerative disorder. And what they saw is that up to 80%, 82% of the patients did develop a neurodegenerative disorder over a mean of 12 years. 16 patients developed Parkinson's, 14 developed Lewy body dementia, 1 developed multiple systems atrophy, which is another neurodegenerative disorder, which is an atypical Parkinson's. 5 developed MCI, mild cognitive insufficiency. So we do see that if someone is diagnosed with REM behavior disorder, they have a very high risk. At 5 years, it's a 35% risk of developing a neurodegenerative disorder and 75% at 10-year mark. So that's quite significant. There was just a very recent study that came out in 2019. They followed the same, a larger amount of patients who had REM behavior disorder. And that study revealed that 97% of the patients with REM behavior disorder eventually converted to some form of neurodegenerative disorder. The majority, in 14 years, developed Parkinson's disease. So if you look at this red line here, so they started off here, and about the 3-4 year mark, they started branching out to other neurodegenerative disorders, but the most common was Parkinson's disease. The red line is Parkinson's disease, and the second most common was Lewy body dementia. So how do we manage, and why do we manage REM behavior disorder? First of all, we have to make sure that how dangerous is it, how severe and aggressive is the patient's dream enactment. We have to educate the patient, understand, and the bed partner and the family members, understand what it is and why it's happening, and discontinue any REM behavior disorder aggravators, such as medications that treat depression or anxiety, SSRIs, SNRIs, etc., if possible. If not, we choose to start with melatonin, which is first line, especially in patients who have cognitive impairment, because the second option would be clonazepam, which is more effective, but may alter cognition. So in patients who have dementia, we try to stay away from clonazepam and try melatonin first. And the doses that we give are higher than 5 milligrams. We prefer 10 milligrams. There was a recent study out that looked at 4 milligrams and compared to placebo, and 4 milligrams did not help with REM behavior disorder treatment at all. One thing I want to point out, that when we treat REM behavior disorder with clonazepam or melatonin, our purpose is not to help someone sleep. It's not a sleep aid that we're giving. It's just to control the REM behavior disorder, just to control these aggressive behaviors. So a lot of patients come back and they don't realize that it's meant that melatonin, for example, is meant to treat those. And they tell me, oh, I don't need melatonin, my sleep is good. So you have to understand that it's not to help your sleep. You may be sleeping well, but it's to help your acting out behavior. So there's also a very recent study, which I thought was interesting, about the dream content itself. We're moving away from REM behavior disorder, but I want to talk about the dream content. Oftentimes we wonder, like, why did I dream what I dreamed, and what's the significance? So what they looked at is 58 patients with Parkinson's disease, and they followed them over 4 years. And they found that there's an independent association between negative emotions and dreams and cognitive deterioration. In other words, the more aggressive the dreams, the more nightmares or disturbing nightmares they have, the higher the risk of developing some cognitive decline over time. So I thought that was quite interesting, and it's not something that we really look into. Switching gears to excessive daytime sleepiness, although it may not be related to, it's not a sleep problem per se, but it definitely affects people's daytime. So up to 50% of people, up to half of the patients with Parkinson's complain of daytime sleepiness or fatigue at some point. And it may end up being that most patients sleep all day long and are awake during the night. Now, that can have a lot of causes. So we really have to understand the cause. It could be because Parkinson itself impairs arousal systems. It affects the circadian rhythm, the sleep-wake pattern. Some dopaminergic medication can cause excessive daytime sleepiness, or poor sleep at night may also affect patients' sleep or cause them to feel sleepy. And there may be some other primary disorders, sleep disorders, such as sleep apnea, restless legs disorders, restless leg syndrome, etc. That may be causing excessive daytime sleepiness. The more severe the Parkinson, the more advanced the Parkinson's disease, the higher the risk of excessive daytime sleepiness. Patients who have dementia or depression also have a higher risk of daytime sleepiness. Now, how do we manage sleepiness? We look at their meds first. This is kind of the first thing we want to do. If they are on dopamine agonists, maybe we should decrease them or replace them with something else, as dopamine agonists do cause excessive daytime sleepiness. They cause patients to fall asleep abruptly or feel drowsy. Do your best to stay awake. I know it's easier said than done, but try to keep the patient awake with different mental activities, physical activities. Go outside for the walk as long as the weather is good. And here in the Northeast, that's not guaranteed. But if you see a sunny day, just push yourself to go outside and get some light exposure, which is crucial and very beneficial for consolidating that sleep-wake pattern, that circadian rhythm. Now, if that's not helpful or it's very difficult to achieve, we sometimes use stimulants such as modafinil or methylphenidate or amphetamine. And another question that we have for our patients who are very sleepy is, how do you sleep at night? Because if you don't sleep well at night, of course you will be sleepy during the day. So we want to address that aspect as well, which we will be talking a little bit later. Now, very importantly, if you are sleepy or if the patient's very sleepy, please be careful with driving, because we do not want them to get involved in an accident, sleep on the wheel. So if you're sleepy, don't drive. So let's talk a little bit about insomnia, which is a big topic. And I would say REM behavior disorder and insomnia are the biggest concerns of most patients with Parkinson's disease. So what is insomnia? It's difficulty initiating sleep, so difficulty falling asleep. It's difficulty maintaining sleep. May also involve early morning awakenings, like waking up at 4 o'clock in the morning and not being able to go back to sleep. And as long as it's accompanied by daytime impairment related to sleeping difficulties, then that's considered insomnia. If someone feels they don't sleep well at night, but they can function well during the day, they don't feel sleepy, then that's not considered insomnia. Now, all these symptoms have been, in order to be diagnosed as chronic insomnia, there should be present for at least 3 times a week for at least 3 months. So, how common is insomnia in patients with Parkinson's disease? Well, that has been looked at. The general population is up to 30%. However, in the Parkinson population, may reach up to 80%. So it's much more common than in the general population. And let's talk a little bit about who gets insomnia, at what stage. So they looked at different stages, and what we saw is that in mild Parkinson's disease, about 25% of patients report trouble falling asleep and a little bit or maintaining sleep. However, as the disease progresses, in moderate Parkinson's, the sleep maintenance insomnia is more common. So patients have trouble staying asleep and less so falling asleep. Overall, 18% of patients with Parkinson's reported they could not fall asleep. 31% reported difficulty staying asleep. And overall, 39% of patients with Parkinson's reported that they felt they didn't get good night's sleep. They didn't feel their sleep was refreshing and restorative. So difficulty maintaining sleep is more common. Now, in terms of insomnia, we talked about the prevalence. It may reach, in some other studies, may reach up to 98%. Women suffer more from insomnia than men do. And we really need to dissect the causes of insomnia in order to treat them. Because in Parkinson's disease, there's plenty of reasons that lead to insomnia. Most common is frequent urination. Patients wake up frequently during the night and may have trouble going back to sleep. Or even if they don't, if you wake up at 5 or 6 or 7 times at night to urinate, you can't get a good night's sleep. So we always need to address that and ask for that. Then difficulty turning over in bed, painful muscle cramps. These are signs that the patient is wearing off at night. So we have to address that as well. Patients may have nightmares, as we talked about. They may have a limb dystonia. Dystonia is a constant muscle contraction that can lead to pain, like jerking or movements, REM behavior disorder, and a condition called periodic limb movements of sleep, which I'll talk about in a little bit. Patients who have depression or anxiety have a high risk of developing insomnia. I remember in the beginning I said that women have more anxiety and more depression than men do in women who have Parkinson's. So that's why women have a higher incidence, a higher risk of getting insomnia or having trouble with their sleep. The longer the duration of the disease, the higher risk of insomnia. So this is how we approach insomnia. That I love this slide because it really shows how we look at insomnia. And we look at different, and we ask all these for the patient when they're coming in for a sleep consult. Like we explore mental health issues. Do you have anxiety? Do you have depression? Do you worry too much? Is there any psychosis involved? And then nocturnal motor symptoms. Are you wearing off at night? Do you have dyskinesias? Or do you have pain in the non-motor symptoms? Do you wake up frequently to go to the bathroom? In terms of treatment, you want to explore and review the medications for that patient is being treated for Parkinson's, because maybe they may be affecting the patient's sleep. We also look at sleep disorders such as sleep apnea, for example, that may be disrupting sleep. And last but not least, um, behavioral disturbances that affect sleep, such as the most common example is if you nap too long during the day, it will disrupt your sleep. So we really have this holistic approach in sleep and try to manage each different cause of sleep disturbance or insomnia. And let's go one by one, through one by one. So in terms of motor symptoms, you want to ask, or tell your patient, your doctor, if you have tremors, muscle stiffness, dystonia, trouble turning over in bed, which eventually leads to you feeling very, very uncomfortable. So motor fluctuations at night in general. We know that patients who have at baseline a lot of motor fluctuations during the day report greater insomnia over time. So if you feel that you're very slow and stiff at night, if you have tremor every time you wake up, or if you have dystonia, if you have pain, if you wake up multiple times to go to the bathroom, discomfort from difficulty changing position in bed, maybe you should tell your doctor, because that's what could be causing you to wake up and not have a good night's sleep. So how do we manage these symptoms? All of these motor symptoms are most of the time an indication that the patients are not well treated. They're under medicated. So that leads to all these motor symptoms. So we may want to consider long-acting dopaminergic medications, such as long-acting carbidopa levodopa, or a dopamine agonist, long-acting dopamine agonist. Rotigotine patch has been looked at in sleep and actually has been shown to improve morning off times and motor scores, and eventually, as a consequence, improve sleep. Other treatment options, not specifically for sleep, but definitely help sleep at night, is the intrajejunal levodopa gel, also known as Duopa pump. And last but not least, deep brain stimulation does improve sleep tremendously. It's been shown to improve sleep quality, sleep duration, helps patients fall asleep, and improve sleep efficiency overall. I also want to touch up on a condition that we frequently see in patients with Parkinson's, restless leg syndrome. Restless leg syndrome is really a sensory problem where patients have this urge to move their limbs, and it's very, very uncomfortable. Usually this happens at rest when they're sitting in the evening. And the symptoms are partially or totally removed by or relieved by movement. They looked at patients with Parkinson's versus controls to see how more common is it in patients with Parkinson's. Actually, they did see that almost up to half of the patients had restless legs, whereas only 10% of the population has restless leg syndrome. So what is those symptoms like? It's something like patients describe it as creepy, crawly feeling, worms or bugs crawling in their muscles, or water running under the skin, something very uncomfortable. And it just goes away once they walk it off. It usually affects both legs, may affect the arms, but not commonly. And why is it a problem in sleep? Because when patients have restless legs, it really prevents them from falling asleep. They're so uncomfortable that they can't get to sleep. They can't get comfortable. That leads to fewer hours of sleep, increased number of awakenings. And they also are related to what we call periodic limb movements of sleep. This is just like a periodic jerky movement of the legs that eventually may wake up the patient, definitely the bed partner. So they sometimes coexist. And how do we manage restless legs? Well, first of all, we want to avoid anything that would aggravate the symptoms, such as caffeine or alcohol. Some medications Antidepressants are the most common ones that worsen restless legs. Another thing that we want to do is look at the ferritin and iron, because if the ferritin is low, you may need to get iron supplementations, because low ferritin worsens restless leg syndrome and makes it more difficult to control. Luckily, the management of restless leg syndrome involves a medication that you may be very familiar with, dopamine agonists. So it's kind of killing two birds with one stone. So dopamine agonists work very well in treating restless leg syndrome. Anyone, pramipexole, ropinirole, rotigotine, they all work very well. If for some reason you're not able, or you have side effects and you can't tolerate dopamine agonists, gabapentin or pregabalin is our next choice, which are also very, very effective. Very rarely, and extremely rarely, I want to say, opioids are also helpful. Another topic I want to briefly touch upon is nocturia. Nocturia is urinary urgency and frequent urination at night. That is a symptom of Parkinson's disease. It's an autonomic dysfunction. The patient's bladder is overactive, and the patient wakes up thinking that they need to urinate multiple times at night. Of course, that disrupts sleep. So if we're talking about the symptom, obviously the patients need to get a urological evaluation, making sure there's nothing else causing these symptoms. And if in fact it's just a symptom of Parkinson's, we try to treat nocturia with medications that would relax the bladder muscle, so the patient is able to sleep better and they don't have to get up to go to the bathroom as frequently. So another tip that we give our patients is try to limit fluid intake before bedtime, somewhere about 4 to 5 hours before you go to bed. You just don't want to drink as much, because that would lead to more bathroom trips. Going through mood disorders, we always want to make sure that the patient is having or not having depression, anxiety, hallucinations, or psychosis that may disrupt patient's sleep. And also exploring the patient's behavioral behaviors around sleep, like how many times do they nap during the day? Because if it's excessive, obviously they will weaken that sleep drive at night and will affect sleep maintenance, as well as falling asleep. Anxiety, depression, and rumination can definitely affect patients' sleep. And some dysfunctional sleep beliefs. For example, some patients think that watching TV in bed puts them to sleep and is helpful for the sleep, where in fact it's not, because light and sound will definitely wake them up. I also talked about examining and reviewing medications. So medication effects, some medications that patients are taking for their Parkinson's may affect their sleep. So like we said, dopaminergic medications may cause daytime somnolence, daytime sleepiness. And maybe causes them to sleep frequently and take long naps during the day. And that would lead to trouble sleeping at night. There's other medications that are associated with insomnia and affect the patient's ability to sleep at night. Some of them that are the acetylcholinesterase inhibitors, which we do use for dementia, such as donepezil or rivastigmine. There's some antidepressants that may affect sleep. And there's also a Parkinson medication, selegiline, which is a little bit of a stimulant. So we want to be careful if someone has trouble sleeping, how we're going to dose this medication. Now, my last few slides are going to be on how do we treat insomnia. First of all, we want to try starting with cognitive behavioral treatment, which is mainly given by a neuropsychologist who specializes in sleep, and retrains the brain on how to sleep and how to stay asleep. Light therapy is very, very helpful. 1 hour of light exposure in the morning and afternoon has proven to help with difficulty in initiation sleep and also improves sleep scores and efficiency, sleep efficiency. Light therapy is also very good for patients who have moderate or severe dementia. They cannot engage in non-pharmacological interventions for insomnia. So with cognitive behavioral treatment, they can't follow directions. So light therapy is actually a very good option to regulate the circadian rhythm and help patients stay awake more during the day. Exercise is also another very good option to keep someone awake and regulate their sleep-wake cycle. Tai Chi has been shown to be helpful because it introduces this low intensity physical activity with meditative movements, and it puts the patients to a relaxed state. I have a few patients who actually practice Tai Chi before they go to bed, and it's very helpful for them. And like I previously mentioned, deep brain stimulation can also be helpful. Not that we recommend deep brain stimulation for insomnia, but as after people have it, they notice that their sleep improves. I'd like to stay on these slides to talk a little bit about tips on how to fall asleep. First of all, regular rise time and bedtime is key. So the brain is a creature of habit. So you want to go to bed at the same time, okay, plus minus half an hour, and wake up at the same time. Only then can you have a good regulated sleep-wake cycle. Get plenty of, I think you already got that part, get plenty of bright natural light exposure. Very, very, very important, especially in the morning. And if you can add some exercise then in the morning, that's perfect. Try to avoid caffeine or nicotine or alcohol before bedtime. Make sure you don't get into an argument or heated topics and of discussion close to bedtime, because that really gets you worked up and worried and thinking about things, and then you won't be able to fall asleep. If you feel the news is disruptive and disturbing, and well, with this past years that we've gone through, I'm sure that it has been a challenge. Try not to watch TV close to bedtime. No, don't watch the news. Watch them in the morning, not so much in the evening. You also want to reserve the bedroom for sleep. So you don't want the bedroom to be your sleep torture chamber, because if you are spending time trying and struggling to fall asleep and tossing and turning, then your brain associates your bedroom as the sleep torture chamber. So you will have difficulties falling asleep. So if you're in bed for over 15 minutes and you just cannot fall asleep, just get out of the bedroom, go somewhere, the living room, and just engage in some quiet activity, and then return to bed when you're sleepy. And a few tips on how to help yourself stay asleep. First of all, your bedroom has to be quiet. It has to be dark. It has to be cool in order to achieve a good night's sleep. Avoid any heavy exercise within 6 hours of bedtime. Any rise and increase in our body temperature or ambient temperature will disrupt our sleep. So you want to really prepare your body to fall asleep close to bedtime. If you wake up in the middle of the night, please do not look at your clock, watch, iPhone. You should not know what time it is. You have nowhere to go at 3 o'clock in the morning, and you don't want to add another worry if it's, let's say, 5 o'clock and you should get up at 6. Then you start worrying about how you haven't slept and you haven't gotten a good night's sleep. So try to stay away from anything that would tell you the time. If you have trouble turning over in bed, try to use satin sheets or pajamas, because that will help you slide and turn your positions in bed. If you go to the bathroom frequently, you may want to consider a commode that may help you minimize the activity going to the bathroom. If you actually go to the bathroom, try not to turn on bright lights. Just a night light, as long as you can see where you're going, is enough. Because remember, light wakes us up. Lack of light helps us sleep better. And a few medications. If none of all these things, suggestions are working, we may need to consider medications. There's a lot of sleep medications out in the market, but there has been recent studies and meta-analysis of what should we use in older patients or patients with dementia or patients with Parkinson's disease. And I kind of have distilled what the recent suggestions are on what medications to use. So these are some of the medications we like using: zopicon, doxepin, melatonin, suvorexant. I have zopicon again, pimavanserin. Some of the medications that we may use. Overall, there's a very strong recommendation against all these what we call Z drugs. Wherever you see Z, so Lunesta is very sedating. We really don't recommend that for patients over 65. Or if we're going to use doxepin, we want to try to use less than 6 milligrams. However, Ramelteon and suvorexant are very, very helpful for patients who have trouble sleeping. For sleep onset, if the age of the patient allows, we could use zolpidem or zopicon, but Ramelteon is also a good option. Sleep maintenance, suvorexant is very helpful, and doxepin. Trazodone or diphenhydramine are not indicated because it can cause excessive daytime sleepiness and what we call grogginess the next morning. So it's not really something we recommend. So this is a nice algorithm that I think kind of puts everything into perspective. When someone has trouble sleeping, you don't want to rush to medications. We have to figure out, why are they not sleeping? So we check all these different problems that they may be having, and then treat that problem individually. And if the patient still has trouble sleeping, we want to engage in cognitive behavioral therapy and exercise. And then if still you are having trouble sleeping, we may want to consider medications. And just to talk a little bit again, review those medications. If you're over 65, these are the medications that have been recommended. If you're under 65, there's a wider range of medications we can use, but overall, we do feel that sleep aids are the last resort, and we don't always go, it's not our go-to treatment option. So I think that at this stage, I would love to hear your questions.
Sure. So Dr. Vaou, we have a lot of questions for you. I'll start with just asking some of the more general questions that we have. One is, how important is it to have a formal sleep study? And, what are your thoughts on that?
So I love this question because sometimes I see it and it's not needed, and it's a big hassle to get a sleep study for the patient. So why get it if it's not needed? So that's a very good question. So like I said, for REM behavior disorder, do you really need a sleep study to diagnose it? If you know that the patient has Parkinson's, most likely it is what you hear and what the patient tells you. So you just to put the confirmation, you absolutely can have a sleep study, and then you can put the confirmation, but it's not going to add to the treatment. However, if the patient tells you that they wake up multiple times at night, they don't know why, they're snoring, or they feeling like they're gasping in their sleep, their bed partner feels that they stop breathing, then we absolutely need to get a sleep study, because that would indicate that that patient has a high risk for obstructive sleep apnea. Another thing that we want to perhaps get a sleep study is if the patient has severe periodic limb movements of sleep. So if they're moving their legs a lot and frequently, you may want to know the severity of this condition, because if it's very severe, it can lead to frequent arousals and awakenings at night. So you want to treat that. So in these situations, we want to do a formal sleep study. That being said, what's also very useful in diagnosing, or again, dissecting the causes of insomnia, is what we call actigraphy. So it's a wearable that the patient wears for 2 weeks in their sleep and awake time, sleep and awake time, so 24/7. And it records their sleep habits. So the doctor, after they return the wearable, has a very good idea of what their sleep is like, how many times they wake up, how fragmented is their sleep, and is it a true fragmentation? Sometimes people think they don't sleep, yet they sleep much better. We call that paradoxical insomnia. So I always consider these two treatment options for a better understanding of sleep. Typically, insomnia, if somebody complains of true insomnia, we want to start with actigraphy, with the wearable. If they are concerned about snoring and problems breathing at night, that's when we add a sleep study.
Thank you, Dr. Vaou. Another question is, how many consecutive hours of sleep does one need to be restorative?
That's a wonderful question. And there was so much information, I wanted to add that too. But thank you that's a good opportunity to answer the question. So it's about 8 hours is what we recommend, 7 to 8. Believe it or not, sleeping too much is not good either. So we want the patients to not sleep more than 9 hours or less than 7 hours. So anywhere between 7 to 8.5 to 9 hours is what is recommended. And there's a reason for that. It's obviously you feel refreshed, obviously you're functioning at your best during the day, but there's also this we know that and I'm going to use very lay terms. So the brain is basically cleared from the toxins that are being built up throughout the day. That happens in sleep. And we have to go through all the stages of sleep and through all the cycles of sleep in order for that to be succeeded. So we have to sleep for those hours for these toxins to be removed night after night after night. And we know that sleep deprivation leads to increased risk. We're talking about years and decades. Sleep deprived people have a high risk for cognitive problems, for dementia, because there's this toxic buildup of toxins, because the brain does not sleep enough to allow this cleaning or reset, so to speak, of the brain.
Thank you, Dr. Vaou. I have another question for you. My doctor said that I have mixed sleep apnea. Is this more common in Parkinson patients? And what does that mean exactly?
Yeah. So mixed sleep apnea means that there's two kinds of sleep apneas. There's the central apnea and there's the obstructive apnea. The obstructive apnea, when there's a physical mechanical obstruction in the airway, so every time you take a breath in it, the air can't go through. The central sleep apnea is when the brain does not give the signal for you to take a breath in your sleep. Eventually you do take a breath, but it's a pause. Some people have both. The most common condition that people may have both is a heart condition called congestive heart failure. In Parkinson's disease, we don't see that there's a higher risk for having sleep apnea, any kind of sleep apnea, central or obstructive. The odds are the same as they would have in the general population. A few years ago, we thought that patients with Parkinson's had a higher risk of getting obstructive sleep apnea, but it's not the case anymore. There are certain atypical Parkinson's disorders that have a higher risk of having central sleep apnea. But in Parkinson's disease, in idiopathic Parkinson's disease, we do not have a higher risk of central apnea or obstructive sleep apnea.
Good. We have another question. Since my tremors do not occur when I'm asleep, why can't we turn off whatever quiets my tremors when I'm asleep, when I'm awake?
Can you please read this question again?
Yeah, sure. Since my tremors do not occur when I'm asleep, why can't we turn off whatever quiets my tremors when I'm asleep, when I wake?
Yeah, I was just like, I wasn't sure turn off meaning DBS or medications, but I'll take it as both, like discontinue therapy at night. That's a very good question. So the tremors, you're right. The tremors do not, when we're sleeping, are not present. They occur when you're awake. So it's not though just the tremors. So the tremors are part of the motor symptoms, but let's not forget that the tremors usually coexist with stiffness, muscle tightness, stiffness, which can lead to cramping and pain, and slow movement. So if you happen to wake up to go to the bathroom, you may be very achy and slow. And then coming back, you will feel very stiff. You won't feel comfortable when you're trying to go back to sleep. And that tremor might start up again because you're awake. So overall, people who are under medicated or are not being treated throughout the nighttime, in the early stages of Parkinson's, they can do it. They don't have so much discomfort, but as we move on to more moderate PD, patients become very uncomfortable and they have pain because the lack of dopamine, because the muscles get very tight and rigid. And they wake up in the morning very, very stiff and very off before their morning medications kick in.
Good, thank you. I just have a few more questions. One is, Dr. Vaou talked about napping too long affecting insomnia. How long is too long?
Very good question. Yes, so anything over 20 minutes per day is long. So we don't want you to sleep more than 20 minutes. Just one cat nap, just one nap is enough. We don't want you to sleep 2 to 3 hours or 1 hour even, because that will disrupt your sleep. Now, having said that, if you do not have trouble sleeping at night, you're mostly welcome to nap. So if you're napping and you also sleep at night, that's fine. You don't have to stop your naps. That is only for someone who has trouble falling asleep and staying asleep at night.
Right. Can you, Dr. Vaou, please just repeat the wearable device used during sleep studies?
It's called actigraphy, actigraphy.
Okay, thank you. And so that concludes all of our Q&A components. We want to thank Dr. Vaou for a wonderful presentation, and thanks everybody for participating. If you could move to the next slide, please. So I want to tell you a little bit about the Massachusetts chapter of the American Parkinson's Disease Association. We have an INR center here at Boston University Medical Campus. The phone number is 617-638-8466. Referrals, resources. We do education and support here in the state of Massachusetts, as well as the entire country. Today we had a representation of a cross-section of the entire United States, and we want to thank everybody for participating in today's presentation. The APDA also provides health and wellness programs throughout the entire country, including fitness professionals training program, and we have the APDA National Rehabilitation Resource Center here at BU Sargent College. If you'd like to connect with us, you can actually move to the next slide, please. We have all different ways for you to connect. We have each chapter that we have with the APDA has a newsletter that is distributed on a regular basis. We also have social media, Twitter, Facebook, and Instagram, as well as our APDA MA.org website.